the biopsy's not back yet. We just wanted to make sure that we, like we check everything and go from there. So do you think you need something better to control your pain?
Well, I would like to, because like when I first get up, if I lay around, it's not so bad, but when I get up to do something, like sometimes I'll just cook a little bit of stuff, and it'll start hurting so bad I'll have to go sit down. And I'd like to be able to do a little bit of something.
Right, because we talked about the best way to really get that with an immediate relief is to do a little bit of radiation on that part that's hurting because of the tumor that's there. Again, I don't know if that's even a possibility. I'm not the radiation doctor. They look at your MRI and then they pinpoint exactly which of you have like 2 that I thought would be the pain, and then there's 3 that I could see, because that would be instantaneous relief, about 2 weeks, like you'll begin to have some relief if he agrees that that's the cause of the pain. We could bridge you with some sort of pain medicine if you have not really done 2 Tylenol, like 2 extra strength, like 1,000 milligram Tylenol twice a day, one before bedtime and then in the midday. That would be another one. Then the next step is narcotics, right?
Yeah.
Problem that I have with narcotics is it could be habit forming, and then we don't know, and then we have a hard time withdrawing you from that treatment. I could start you on one, and then, and then we could go from there, but it's not a good solution for a long-term control.
Yeah.
Right? Because of, it's just, sometimes it masks things, and I'd like to know what we're doing it for, right?
Yeah, I understand.
Yeah, so I don't know, so.
I would like to try to go with that.
Yeah.
If I thought I was going to live a long time, it would be totally different.
In what way?
Worried about getting addicted to it or something.
Well, what is the definition of a long time? Because like I said to you, for your condition, we could keep doing some sort of treatment, and it's usually measured in years.
Oh.
To me, that's a long time.
Well,
You're not dying.
I wasn't measuring it that way.
No, I said that to you, right?
Well.
Like, you're not gonna die in 6 months. You're
okay.
not, if I have to bet, you're not gonna die in 1 year either. I said to you that this first line of anti-estrogen therapy, the average person with the same condition as you, the average, meaning it's a bell-shaped curve, right? There's the majority of the patients that were on this medicine had good disease control for 2 to 3 years, right? And there's the one that defied the average by 5 years still and going, and there's the one that were below the average, because that's but the average was 2 to 3 years.
Okay.
That's your first one. Then we go to the next one. Then the next one. Then the next one. That's not even chemotherapy, right? Because then once somebody used up all the estrogen therapy and we move on to chemotherapy, usually that is another 2 years at max, right? So you stack all of these together, and so that's why you're right. If it was 3 months, 6 months, I agree. You can have all the narcotics you want, but that's why for this kind of condition, I'm a little bit. Let's make sure we have a goal, right?
Yeah.
It's temporary, and it's this, and that's why we offer radiation, because it's a quick fix that lasts forever on that same side, right?
So if she did radiation, would that be a lot of treatments or just a few?
Just a few, not like a month or anything like that. Sometimes, again, it depends on the size. And again, I don't even know. He might come back and say, you know what, she'll be better managed by narcotics until your breast cancer treatment kicks in.
Yeah.
But, again, this is why we do that option.
Well,
And
what
you-
about the Tylenol then?
You could also try that, I don't know what, if you're doing that.
She's been taking
I take 'em.
Tylenol.
Yeah, like I said, we could also then add a narcotic,
Yeah,
but you know, you're gonna have the constipation, and it's not good for long term, right?
yeah,
Because every time I write a narcotic, you can only get a few, and then you're on a database that is now getting monitored, you know, carefully, and then, it is something where I'm the only one that can prescribe it, and then it gets to be very cumbersome because I can't just call it in. It
yeah,
has to be like either, you know, sent through the computer to computer talking, and then it requires 2 authentication from my part, right? I mean, you know, I almost want to, my, you know, firstborn for me to write even a narcotic. So I'd like for you to see the radiation doctor if you want to do that.
that's not really what I want.
Okay.
She's scared of that.
Why?
Well, I don't know, I guess because of where it's located
Yeah,
and things, and of course, my sister had radiation and it burned her.
right, but
And
you're not gonna get burned with this, cause that's totally different, right? So if we are, it all depends on the area, right? And the purpose of what you're doing. If you are aiming to really get rid of all of the disease, like curative intention, you know, you will offer tiny doses of radiation in that tumor on the breast for a good 6 weeks. And it's not because they're giving her a lot, no, there's a certain prescription, but you can only give small because you're trying to
Yeah.
reach where it is. Because if you just give them a whopping 1 big dose of that radiation, the whole breast is gonna fall apart.
Yeah,
But
well, that's not the
the
sister
problem
I'm
is,
talking about.
Like, you know, the problem is you have to give it in little flicks over a 6-week period, and then you exhaust that tumor. And then the outside skin, to get to where it is, does have the suffering or the collateral damage, but it heals. Now, for your bone, I should try to see if I like computer. If you, I'm not a good drawer. Let's see if I can draw it carefully. So that's your spine, that's your back, right? And it looks like this. And then your spinal cord is right here. So spinal cord, right?
Mhm.
And then this is your inside your body, that's your back, right?
Mhm.
And the tumor is right here for you. Okay?
Okay.
When they give radiation, they block all of this. They will put a guard, right? And then they will calculate the dose so that by the time it reaches this part, it's gone. So it just does that because you have your organs here, your internal organs here, right?
Mhm.
You don't want the radiation to go all the way there.
No.
So they calculate that to do so that it does not get any residual, you know, that. Just like if you are so sunny outside, and the reason why you either want to wear a hat or an umbrella, or if you're at the beach, you want to be in the shade because the radiation from the sun
Mhm.
is not good for you because you'll have sunburn and blisters. Now, if you're there for 10 minutes, fine, you'll get a nice tan. You stay there all day long, you'll blister out
Yeah.
all the way to the fatty tissue of your tumor. But if you put if you put like a little umbrella or a hat, like a sun visor, you're protecting this area. But if you go on a beach umbrella, you're gonna protect a lot. And so they could even angle the radiation table tilts, and it's less than 10 minutes, so that the ray or the effect actually goes outside your body. You know, those are the things that we do.
Yeah.
Depending on the area, the bone, and what's the dosage. if the, because there's actually a maximum tolerated dose by an organ, right? And so for bone, and if you're palliating just to get the pain away, you just wanna go just a little bit. You don't have to fry the entire, well, you can, you won't. And so that's why radiation oncology is like, it's a field of doctor, because they study all of the physics, the angle, what's the maximum tolerated dose of the nearby structures. All of those play into an effect of what they do. So, so that's what radiation is. It all depends on the side, the organ, what's surrounding it, what the goal of the treatment is, what is the purpose, right?
Yeah.
Of course, if you go, I wanna, like, we have cancer, lung cancer, and it's by itself, and the patient can't really have surgery because, for some reason, too young, too old, too many sickness, the location, and it's just one little tumor in the lung. They're gonna radiate that, but they're not gonna give them a dose that will create a hole from here to the back,
Yeah.
right? Because there's a known calculated dose already, so we're not in the 1900s, that we know what the maximum tolerated dose of a lung tissue is. And then they put a block so that only that area is radiated.
So it wouldn't be right on the spine, huh?
No,
See, that's what I was thinking.
no, that would be bad.
Yeah.
She's afraid she might end up in a wheelchair.
No. Well, then you'll be rich because we'll sue Dr. McMahon. You'll tell him I said that. Never.
Well,
Never.
if it will do away the pain, it would.
Yes, I think that I want him to see first what we could do,
Yeah.
and then if he thinks you're better managed by narcotics. The only reason why I say this, if my anti-estrogen for you acts that fast, then fine, let's wait. Thing about anti-estrogen is it's not an instant kill to the cancer.
Yeah.
It's starving them, right? So it's not suffocating them, it's starving them, and then they just slowly wither away. It's not fast. Okay?
Okay.
That's why. Secondly, you just have to talk. You don't have to do anything. But I think you'll find that really, I know what you're afraid of. They're not going to go in your spinal cord. Well, that would be awful.
Well, that's,
And then there's actually tumors that no one, that all of a sudden it gets so big that it ends up going to the spinal cord and touching it. And those people present paraplegic. And then
Yeah.
depending on how long they felt this, if we do radiation, the spinal cord, the nerve actually hits and they walk again. So I have a patient who, the one I saw this morning, I'm not breaking the law here, when I met her 9 years ago, she was paralyzed from her neck down. Paralyzed from her neck down. I saw her in the ICU when I was at IU, Methodist Hospital, and all she could do was blink at me, okay? That we had to do surgery and give her a new spine and remove the tumor from the spinal cord. Did I tell you, that was 9 years ago and I just saw her. Okay?
Okay.
All right. So you got the medicine in the mail,
Mhm.
right? You're gonna have to really find a calendar, right? Like a good old big calendar.
Mhm.
I'm still old school. I can
Yeah.
figure out my phone. And you have to write your day one. And we talk about it like this, day one instead of
Yeah.
1 day. Day one, because you're gonna take it 21 days
Mhm.
and then you have a week off.
Yeah.
The reason why we give you a week off is because it decreases your blood counts. And we have to monitor that, okay? Because when your blood counts decrease, you can have infection risk, anemia, needing blood transfusion. I've never had to give somebody blood transfusion for this, but it can happen. And then the platelets, which is the one that monitors bleeding and clotting, can also go down. So you haven't started, have you?
No.
So today will be your day one.
Mhm.
And then in the 14 or 15 days, we just need to check your blood count to make sure that you're not the one that's gonna bottom it down. and then we check it again on the beginning of the cycle, right? About 2 to 3 months into this kind of schedule, we'll know how your body does it. And then, by then, either I've adjusted or kept you on the same dose, you know, and then by then, after a while, I only see you about once a month or once every 2 months or so. Then you'll be on cruise control. In the meantime, during all of this, we watch the breast, we measure, we may, you know, probably need to repeat the scan about 3 months into the treatment. Again, why? Because it's a slow process, right? If I scan you 2 weeks later or 4 weeks later, it'll say nothing's happening, right? Okay?
Okay.
Mild nausea, not much, you know, it's just some fatigue because when your blood counts do drop, you feel tired. And, you know, and we just stop it mid-cycle if there's a level that we check, there's a number, and then it recovers. If you don't really kill your blood cells, what you do with this is they make them stop growing.
Yeah.
Right? So, because it's also stopping the growth of the cancer, and your bone marrow cells are also actively dividing like the breast cancer. So again, it's another collateral damage. And then you stop the medicine, they grow. Okay?
I think I understand.
Yes. And then you already started the one that I gave you.
Yeah,
the prescription.
yeah.
So that one is continuous.
Mhm.
That one can cause hot flashes and, you know, like menopause symptoms.
Yeah.
And sometimes it can exacerbate arthritis also with that medicine. And then you're gonna get, because of the location of the tumor, I asked for permission, doctor asking permission from an insurance company, if I could please give you a medicine that will give your bones strong. And I will have to see if it got approved, okay?
Oh, okay.
And then you need to take some calcium to build bones. Okay. Over the counter, at least
Okay.
2 of those. Calcium, vitamin D. They're all, you know, I don't care.
Yeah.
There's a gummy bear, there's a fruit gel, you know. I do the candy one, because it bakes me out like it's a candy. There's a Tootsie Roll looking thing. I mean, or some people go, let me just get a tablet. You have a plethora of choices, like, you know, get the generic one, take 2.
Okay.
Okay?
Now, can she get like a Zofran or something in case it makes her sick?
Sure. We'll send it to who?
Walmart in Salem.
Salem. Okay, we'll do that.
It should be on her chart.
All right. Okay?
Okay.
So then have you just talked to the radiation doctor also? So, do you agree, all of you?
Okay.
Yeah. Okay?
Mhm.
All right, hang on a second. Lots of stuff here. I know. Plan it with Caitlin. Do you guys have any questions for me? And then I'll measure.
What about the genetic testing?
So it's not back yet.
Oh, okay.
Yeah, so that takes a while.
Okay.
So we'll keep an eye on that, okay?
That's what she told me.
Yeah. Okay?
Okay.
All
thank you.
right. Okay, so